Hi, that was fantastic from everyone. I'm Shirley Alexander. I head up the weight management services for the Children's Hospital at Westmead, so I'm probably one of the few paediatric health clinicians here. And we are the poor cousins. If you think you're badly off, we're even worse. However, I have to say, being the Premier's priority for the last 4 years, tackling childhood obesity in New South Wales anyway, things have improved. A couple of things I'd like to ask. So, for example, we have a 5-year-old who's just had a liver biopsy and has fibrosis already. The access for bariatric surgery in the public health sector for adolescents is absolutely non-existent. And I just wondered what people felt about that and how we could move forward with that. Also, is specifically for Dr. Ali, is adolescents included in the framework for public bariatric surgery? And third question is, what do the panel feel about the age group of 16 to 18? As a tertiary hospital, we only take up to 16-year-old new patients. The adult sector take 18 and above. And so we have a huge gap for the 16 to 18-year-old adolescents, where in fact the prevalence of obesity is increasing the greatest. What are we going to do about that?
No, the framework deliberately didn't look at adolescents or children because we recognised it as a specialist area that will need to be looked at. But given the frame of reference that we were working with at the time, and actually, whilst it seems like a relatively simple thing to do, to get national consensus of all those stakeholders talking about surgery in itself was a major milestone. And that's the reason the framework's so important, is it's a very strong advocacy tool when it comes to policymakers. If we're going to increase our services in the public hospital, we need to be able to speak unanimously and say this is how it is done and here is the evidence for it. And that's the strongest tool that we can provide the policymakers for. Then they have no excuses. There's nowhere to run and hide. And we understand the economics of it and their models of funding and so on. So we haven't tackled the adolescent question. Again, I think a lot of that is also to do with the fact that in the bariatric surgical world, we don't know the answers. This is a really controversial area, not just from the basis of scientific evidence, but purely because of the emotions that it carries. Already obesity has a stigma. Surgery has a stigma, which is breaking down slowly, but it has a stigma. When you start talking about surgery in children, you might as well put a target on your head and, it starts. Not that it's not valid, not that it doesn't have a role, but exactly what that role is and how to sell it is really difficult at the moment. And people are working through it. I think we will get there, and I completely understand your desperation, if I use that word, because I think there is definitely a role. The more that all of the stakeholders of obesity can talk with one voice in this and say that it is valid and required, the easier it will be to create that transition.
I just want to add one comment because I think it is relevant when Amit's talking about the evidence. I think one of the issues is we didn't have evidence for a long time. Might be scattered studies here and there or small numbers, but I'm just reminded in Journal Club at Blacktown we just covered the New England Journal paper which actually looked at bariatric surgery in adolescents, comparing them to adults. And children, they actually, adolescents, they do better. They actually have higher rates of diabetes remission, improvements in hypertension more than adults, and less complications. So we actually have some evidence to show that there is actually some benefit here. What we don't know is the long-term benefits. We have 12-year data for gastric bypass in adults. We just, published that. That was not us, but it was published last year or 2 years ago. We don't know the long-term effects of, bone health, gut health, cancer risk in these children. So I guess that's where I find the impediments is when you go to policymaker, you want to know it's safe, not only short-term, but long-term. We have some short-term data finally, but long-term data, I think, is a long way off.
And that's absolutely right, which is why I think we need to be conservative and circumspect with it. But it is important to give the message that it has a place and a role, and maybe it's this NASH patient. And notwithstanding that maybe we don't quite know what happens in 20 years, but right now that patient needs it, because if we don't do something, the outcome's worse. So we need to all be giving that message. If this has always been a plague with surgery, where it's very easy to sell prevention. Well, relatively easy to sell prevention, because that's popular with the voters. Right? It's much harder to sell something like surgery or pharmacology or whatever. That becomes more difficult in this area. So we need to keep giving that message. I agree, though, who we select for that surgery, that needs to be conservative, and why it needs to be multidisciplinary amongst. Again, coming back to the networking of institutions and the expertise.
Can I ask one of the questions Shirley was querying about was the access to public clinical obesity services. I was wondering, maybe Rami and Sarah, you could comment on, there's an age limit, they take in patients, the gap, the 16 to 18-year-olds. I know some services do. I know that Nepean has, sees adolescents or 16-year-olds, but do you have any suggestions for Shirley about addressing that unmet need in that target age group, which doesn't, it's too old, they're too old for paediatric services and they're not old enough for adult services?
I think it's a really relevant point, and I'm thinking about our eligibility criteria for both our Shake and bariatric clinic, and I'm pretty sure both of those say 18, but after your discussion there, you're absolutely right. Paediatric care does finish at 16, and that is a key population group that we want to keep engaged at the very least and to be offering treatments to. So I think we as a centre, we need to review what we've got there and potentially take it. I take your point that in terms of bariatric surgery, you would certainly want to take a fairly conservative approach in that young age group, but there is evidence of benefit, and I think nonetheless we don't want to lose that patient population. So I think we should all be reviewing what we do in terms of access to our clinics.
Can they wait 2 years?
No.
We have 11-year-olds that are 193
Yeah.
kilos, 15-year-olds that are 210. We actually had to ask IT to change the growth chart to include up to 250, because if you put in 210, it wouldn't compute it and it just threw it out. So, when I first started, we never had children like that.
Yeah.
We're getting them now. And adult hospitals take 16 in ED. Why don't clinics take them at 16?
But can I just ask, I think as an adult, I'm certified by the Royal College of Australian Physicians. Am I allowed to see people who are not adults? Are we allowed? Because I know a lot of, for example, Kath Williams and Nepean will look after children, but I thought it was a legal responsibility that we cannot see children.
No, it's about consent in terms of being older than 16 and therefore the consent angle of things. So under 16, I think, though we could see children, in terms of consent, it becomes more complicated, and obviously that deserves a paediatric population. But my understanding, Georgia, you might be able to add in from a GP point of view, but it's really just about consent between the age of 16 and 18. And if you deem it as somebody being able to make that consent, then they could certainly be seen.
There's a few criteria for the GILIX competence, and if they satisfy that criteria, then it'd be fine. But I echo your words. We've done with Shirley some work for New South Wales Health, and we've identified there is a gap. Even the Go for Fun program stops at about 15, 16. The Get Healthy program starts at 18, so there's that gap. 16 now, okay, it was 18, so that was actively pushed for, so I'm glad to be corrected. That's obviously a new development, but yes, I agree, and we wouldn't have a concern in our adult clinic to actually engage the 16-year-olds. But as Ahmed said, we'd try to be very conservative in the management, but we want to engage the whole family. As we know, for children and adolescents, we need to engage the whole family in.
Thank you. I'm interested in the idea of the bariatric surgery in youth, and the best data for that that's been published came from the Swedes. And for the Swedes, they are the most prolific surgical group in terms of proportions that actually get to surgery, though the US obviously do more as an absolute number. But the Swedes only allowed 3 centres across Sweden to do the bariatric surgery in the under 18 group. And it comes back to one of Ahmet's slides that you showed how many hospitals, public hospitals, out of 700, that tiny number, that were doing bariatric surgery. I'm interested in your view, as should every hospital offer a public bariatric service, or should it be concentrated into centres of expertise so that there are no adverse events and the expertise is very high? Because if there is a catastrophe, for example, in a small centre that doesn't have the full setup, or in youth, that would be a huge backlash politically that might stymie future bariatric services. I'd be interested in your thoughts.
So with respect to surgery, whilst that's an attractive idea from a quality and safety perspective, so I understand that, and also in surgery we have many debates around volume outcome relationships. The problem here is you have a very high prevalence disease. And the number one fear of policymakers is floodgates and waiting lists and stagnation. So the problem with centering it on a couple of, there's a number of problems, but having only a few centres is there is no way to avoid, even at a 1.5% penetrance rate, an enormous waiting list problem that occurs, which then also creates a lot of problems in maintaining that service. And it's because it's such a high volume disease. That's the political problem with having just a few centres, is that floodgate issue and the cost associated with that. The other equity thing, however, it comes back to Alison Venn's data, where 35% are regional. Okay, for example. So that's why I think we need to think broader than that. It's not to say that every hospital needs a service in the same way that not every hospital provides all the other services. But services that are interested, services that are geographically important in delivering, should be given the opportunity to develop a service along a set of criteria. And part of that criteria is mandatory contribution to the National Registry, which allows benchmarking and monitoring of quality and safety. So if they become an outlier for some reason, it can be picked up relatively early and addressed. But it also means that, that within the framework we provide guidelines on, for example, what is required if you want to be doing complex revisional surgery compared to if you're going to restrict yourself to simple primary surgery of a patient category as well in terms of risk. We don't want to discourage that type of service developing, because after all, they can still treat some patients. They can't treat all the patients that might be referred to them, but they can treat some. However, they must be linked with another institution that can provide the complex surgery or the higher risk patient. And conversely, if they do have a problem, if a problem did occur that they're not equipped to manage, there is already a pathway for the management of that patient, and that has to be by formal mutual agreement. So essentially, many institutions might be networked into one service, so to speak. There's a lot of work to get there, but conceptually that's the idea. Because I think if we make it too restricted to single centres, we don't actually increase access very much.
I think Ahmed was suggesting that the opportunity to do that is to improve our networking or our pathway models to increase access across hospitals, rather than advocating for every hospital to be fully equipped and prepared to provide a clinical obesity service. So 2 last questions.
Tony Brancatisano from Sydney Bariatric Clinic. Question to Rami. Rami, with the Blacktown public system in terms of bariatrics, given the fact that patients have to undergo medical weight management prior to any potential referral for public bariatrics, given the fact that obesity medications cost money, of course, they do, they're not on the PBS, does your service provide access to pharmacotherapy as a process of medical intervention prior to their access for bariatric surgery? So in other words, if a patient responds appropriately, therefore there's potential for a percentage of patients to actually come off the waiting list for bariatric surgery. But the problem that I see is a cost issue for access. So does your system provide cost, in other words, provide an out-of-pocket or no out-of-pocket cost to a patient to access pharmacotherapy as a means of determining their response and likely no requirement for bariatric surgery?
Tony, I think you're pulling up my strings a lot at the moment. So one of the issues we have, of course, is that the local health district budgets. I get very nervous when the budgets are revealed every year. It's every Western Sydney local health district. It's $20 million in the red or $30 million in the red. And I've actually, just in passing up, Novo Nordisk have approached us about developing an innovative contracting for Saxenda. So similar to what you were just mentioning, patients can access this publicly funded pharmacotherapy. Patients who respond, the hospital would bear a cost. Patients who don't respond, pharma would harbor some of the costs. And that's been something that's a fluid space. And at the moment, we're preparing a submission for that. We have looked at getting Duramine and Topiramate. I know RPA have Topiramate on the formulary as an indication for obesity off-label. You've got both and phentermine. Thank you, Samantha. So that's something that ideally would like to get at the moment, but we're always offset by just getting the basic diabetes therapies on the formulary. One of the issues that we have is how do you translate, a kilogram into cost? Because that's really what the hospital really wants. We want to, advocate for patient efficacy, patient longevity, reduction, mortality, morbidity, etc. But they're less interested in that. And they want to say, if I lose a kilogram, can I prevent them from coming into hospital? They don't care about getting them off the bariatric surgical wait list, to be honest, because the money is there. It's up to you guys to decide who the patients go. What they want to know is, can you prevent them from coming into hospital? Because a day in hospital, it used to be $1,000. I think it's more than that a day now. I'm not talking about ICU, I'm talking about just a general medical ward. So costing obesity in Western Sydney for the hospital that you're working in is a bit difficult. We have costs for diabetes and complex diabetes, lower complexity diabetes, but for weight, it becomes very variable because like Arya Sharma was saying, you have really sick obese people, you have very non-sick obese people. Whether they stay non-sick forever, I don't know. But trying to cost it so that we say if Saxenda can, for example, reduce this many kilograms, the hospital will save this much in potential hospital admission. That's the hard part, and that's the data we're struggling to get at the moment. But if we do have this data, then it would be an easy case of formulary application. We're putting a hodgepodge of information for Saxenda at the moment, and I suspect that Contrave, Topiramate, and Duramine will be afterwards.